First of all, we would like to thank you for taking your time out from your busy schedule today to attend this webinar. So let me introduce you to today's speaker, Dr. Swarnlata. Dr. Swarnlata heads our genetics department. She has a total experience of 10 years in this field and from last 2 years associated with us. She specializes in cytogenetics, genetics and molecular genetics. She has done her PhD in genetics from Osmania University and has almost 7+ publications in her forte. May I now invite Dr. Swarnlata to start the CME session.
Thank you, Mr. Amit, for the quick introduction. Today, my topic is about genetics and molecular medicine in screening, diagnosis, and management of the disease or disorder. So cytogenetics or molecular cytogenetics is a branch of genetics which deals with the study of chromosome number and its structure present in a cell. So we can analyze this by a chromosome 1 analysis by doing a gym-sustained banding or a karyotyping, it's called, or the other bandings like NOR banding, Q banding, and R banding can be done. And other technique, high-end technique when compared to the karyotyping is the FISH technique, where a specified region probe is being made, and to that particular region, the FISH is being performed. And the higher resolution one is the microarray. So by doing this, you can analyze the chromosome number and the structure of the chromosome present in a cell. Whereas in molecular genetics, it often applies to the investigative approach to determine the structure of DNA molecule, which manifests as a variation among humans. So this can be analyzed by a PCR technique or by doing a real-time PCR or by Sanger sequencing or a high-end in next-generation sequencing. Other than these, we have a non-invasive pregnancy testing, which is being done as a screening test for all the pregnant ladies to check the most common trisomies like Downs, Edwards, and Pataus. So this is a screening marker as like you have in the biochemical with a hormonal studies with estradiol and beta-HCG. In the same way, in genetics, you have a genic level testing, which is nothing but the NIPT. So coming to the newborn screening is a public health program of screening the newborn, immediately after the birth, to just to check with the inborn errors of metabolic disorders, which are not clinically evident at the birth, but these are treatable when diagnosed. And usually in cytogenetics and in molecular genetics, there are different types of sample types which have been used. So coming to the cytogenetics, in simpler way to remember is a sodium heparin, where we do all the peripheral blood testings actually. And amniotic fluid also being used for the chromosome analysis, and it can be done even on the POC samples and bone marrow, solid tumors, and formalin fixed paraffin embedded. These sample types are generally used for the cytogenetic testing. And coming to the molecular genetics, we use peripheral blood samples which are given on the EDTA. This molecular genetics can be done even on amniotic fluid samples, POCs, and bone marrow and solid tumors. And newborn screening is being done on a dried blood spot or on a urine sample of the newly born babies. NIPT testing is being done by collecting the maternal blood in the strect tubes, which something looks like this. And this is the amniotic fluid. Coming to the cytogenetic analysis. So we do a cytogenetic analysis by using a fluorescent microscope with an attached camera and a software. We have a cytovision software and also ASI for the karyotyping and also for the FISH. So these are the few images of the karyotype, which is a normal female karyotype, and this is a normal male karyotype. And these are the FISH images, which is, this is the fish image of an amniocyte. This is a metaphase, and this is an interface cell of a bone marrow, and this is a solid tumor. Other than the cytogenetics, we also have a molecular genetic setup where we have a PCR machines, real-time machine, and the gel documentation system for the analyzing the band sizes. And we also do the sequencing. So this is a general test equation form which we use in our lab, which has all the particulars of a patient, which is need to be filled by the client or a doctor or a patient. So before taking this TRF, we also do a pedigree analysis where the family tree is being drawn and the family history has been taken. So here I am coming up with few cases which we have dealt in our lab. So case 1 is a primary with a pregnancy of a single type, came with a history of abnormal antenatal scan showing an increased NT of 7.9 folds and a tricuspid recursion with high possibility of trisomies, done at a gestational age of 15 weeks, 4 days. So NIPT and also the amniocentesis testing options were given to the patient as she had a high risk for the trisomies, because the NT soft marker was very significant for the high risk possibility. So the patient and her partner has been consented for the NIPT testing. So then we performed a NIPT testing for her, and we got the results something like this with a fetal fraction of 13.54, showing a high risk for the Down syndrome, which is 1 in 20. Which is lesser than 1 in 20 with a specificity of 99.99%, indicating a high risk for chromosomal 21. So invasive prenatal testing on amniotic fluid by fish was recommended. And if it is a karyotype and for the further testing, like because it is a high risk case, we have recommended further testing with the amniotic fluid with a fish test of more than 100 cells and a karyotype of minimum 50 cells to confirm whatever has been identified the risk through NIPT. And coming to the case 2, here is a 9-month-old male baby born to a non-consanguineous parent whose father was 33 years and mother is 25 years old. She also had an elder brother she also had an elder brother who is a normal person. Coming to the pedigree, here is the proband who is 9 months old, and the baby has an oval face and cried at birth. Crawling was there, but the breastfeeding was there. But the baby had a flat nasal bridge, round face, chinky eyes, and abnormal ears and indistinct philtrum. The baby, other than these phenotypic features, the baby also had a microphallus, which was not consented to take a photograph. The baby turned out to have an aneuploidy. The results of the baby look something like this. Other than the features of the Downs, the baby also had a microphallus, indicating that the baby has infertility issues too. So the karyotype turned out to be a 48XYY plus 21, indicating a Down syndrome also with an extra chromosome of Y. Here is the Y chromosome and an extra 21 chromosome. So indicating a double aneuploidy case. Next, coming to the third case, here is a couple came for a chromosomal testing. They were non-consanguineously married since 4 years with a history of first baby died after the birth, and it was a full-term female baby. Second pregnancy was a MTP due to abnormal antenatal scan showing an increased NT and suspected to be a Down syndrome. Then we have done a chromosomal analysis for the couple, and the female karyotype showed that there is a pericentric inversion in the chromosome 9 and also a translocation in one of the metaphase with involving chromosome 10 and chromosome 14. Surprisingly, even in the husband's karyotype, we could see that there is a pericentric inversion in the chromosome 9. So leading to the bad obstetric history for this couple. So majority of the bad obstetric history cases coming to the chromosomal testing has a potential identification of only 10 to 20% of the couple cases can be identified who has a chromosomal abnormality leading to an infertility. And case 4, a primate with an age of 36 years came with a gestational age of 20 weeks and a history of abnormal antenatal scan showing a hypoplastic nasal bone suspecting a trisomy. Amniotic fluid karyotype and FISH was done after taking a Form G consent. And it turned out to be a fetus of Downs. This is an amniotic cell on which the FISH test was performed and showing 3 chromosomes of 21. And this is a karyotype indicating a trisomy 21. Coming to the case 5, a male baby born of a non-consanguineous marriage presented with inability to stand, sit, and walk, or a positive Grover sign and hypotonia, elevated levels of serum creatinine kinase, and frequent falls, calf muscle hypertrophy. He has a family history where his maternal uncle and had weakness and was bedbound and expired at age of 25 years. This is a pedigree chart wherein you can see the proband's uncle died at the age of 25 years and the proband is having a Grover sign positive. So I'm just showing the video of the patient. Can you see the video? Okay. Just now we have seen the video of a patient where he was having a Grover sign positive. And we have done, we were suspecting a Duchenne muscular dystrophy. And then we did a MLPA for this patient. And we could identify that there is a duplication in the Duchenne muscular gene at exon 50 to 60, indicating that the Duchenne muscular dystrophy, the presence of Duchenne muscular dystrophy. The inheritance of the Duchenne muscular dystrophy falls under X-linked recessive disorder, and it was classified as a pathogenic mutation after doing the MLPA analysis. So this is X-linked recessive disorder indicating that the mother will be an unaffected carrier and giving rise to a females, 25% of the females to be a unaffected carrier and 25% of the males to be affected and 25% of the females to be unaffected and 25% of the males to be unaffected. So here, in this case, in Duchenne muscular dystrophy, there are 50% of the females will be a carrier and 50% of the females will be a normal. But the carrier screening has to be done to the extended family as they can give rise to the next generation. The counseling has been given that the extended family carrier analysis need to be done. Coming to case 6, here comes a man with a 67 years old, asymptomatic. He has a family history of cancer with one of his brother diagnosed with colorectal cancer. Not visible. Share the slide. It's going back again. Slideshow. Sorry for the interruption. This is case 6. A 67-year-old male, an asymptomatic individual. He has a family history of cancer with one of his brother diagnosed with colorectal cancer at the age of 62 years. And a nephew diagnosed with colorectal cancer and another brother succumbed to carcinoma liver. So this is a proband. This is a proband who had a family history of Lynch syndrome. And this is the family members who have been affected with the colon cancer. So proband has come to check whether he will be affected with the colon cancer. So we have done a gene panel for the Lynch syndrome, and we could find that there is a mutation in the MLH1 gene, indicating that he should be under surveillance by doing a colonoscopy for every 2 to 3 years, as he is above the age of 50 years and also a positive for MLH gene pathogenic variant. Coming to case 7, This is a case of a 19-year-old male came with a history of frequent fever, generalized weakness, and a pain in the abdomen since 1 year. Ultrasound of the abdomen showed a massive splenomegaly, hepatomegaly, and a protosystemic colorectals. We have done a FISH testing on the bone marrow, and we could see that there is a 70% fusion in the BCR-ABL, indicating a presence of a positive Philadelphia chromosome. Our turnaround times for the cytogenetics to do a karyotype, we take 6 to 8 days. Coming to the molecular cytogenetics, FISH analysis, we take 1 to 2 days, and microarray 10 to 15 days. And for the molecular genetic analysis, PCR, we take 7 days, Sanger sequencing 15 days, NGS 30 days, and RT-PCR 1 to 2 days, clinical exome 30 days, and NBS 4 to 7 days. We also offer a genetic counseling, basically pre-test genetic counseling, and also the post-test genetic counseling has been given. It has been given in 3 different forms in our place. Direct counseling is being done through a walk-in, or an on-call counseling, or the virtual genetic counseling is being done. This is our team where I have 2 MSCs and a BSc to do the cytogenetic and the molecular genetic testing here at Medicis. And if you have any questions, please. Do you have any questions related to the genetic testing? Can please come up with the questions. And these are a few of my publications.
Dr. Swarnlata, in the chat box, I can see that Dr. Menal has raised a query saying that is RT-PCR related to genetic testing?
Yes, we do a real-time testing, right? We do a real-time testing, real-time PCR testing. Basically, we can do BCR-ABL, major, minor, through real-time PCR, because it is very quick and rapid. Within a day, we can give the results. And we also can do KRAS, NRAS. We have launched a new panel of EGFR testing through real time for the lung cancers. Hello, can you hear me? Hope I have answered doctor's question.
Dr. Swarnalata, next question is from Dr. Smita, saying that can fish be used to study cytogenetic abnormalities?
Yes, fish can be used for the cytogenetic abnormalities like Downs, Edwards, and all the testings can be done through fish testing.
One more question from Dr. Rohan, saying that NBS is in-house test. First question. And second question is that can be processed by urine sample?
Yes, NBS testing can be done by urine also. I mean, like under newborn screening, there are a lot of amino acids or carnitines or organic acids which been done. As of now, we are not doing it in-house. We have tied up with some company for the newborn screening.
Second question from Dr. Rohini Deshpande, saying that when do you do gene sequences?
When do you do gene sequences?
Yes.
I mean, whenever there is a undiagnosed case or you cannot identify through a chromosomal analysis, the high-end testing is the NGS-based testing or a gene sequencing, right? So in those cases, if there is an undiagnosed situation with the cytogenetics, then we look for a molecular genetic testing.
Question from Dr. Smita again, saying that is cytotoxic action an alternative to cytogenetics?
Cytotoxic action?
I repeat once again.
Yes.
Is cytotoxic action an alternative to cytogenetics?
Cytotoxic action is alternative to cytogenetics.
Yes.
Cytotoxic is generally, yeah, cytotoxic studies can be done through cytogenetics. Like, you know, you can take some media and add the blood, and you can add whatever cytotoxicity, like in whatever maybe the chemical or if you want to see the cytotoxicity in some chemical, like in your food, you can just add that content to your blood and then culture them, and you can look for the breakages in the chromosomes, then indicating that or a comet assay, or you can do a chromosomal testing, and then you can identify whether this toxicity is there or not.
Next question from Dr. Rohini, saying that how can you predict risk of lung cancer?
How can you predict the risk of lung cancer?
Correct.
So generally, there are a lot of factors which play a role in the lung cancer. So first, going any indications of, primarily of phenotypic features, then coming to the familial history and the environmental exposure. These things helps a person to identify whether he is having any cancer. Then if any indications are there from these three, then you can do a basic screening test for the lung cancer, and then the further testing can be done to identify whether he is having any lung cancer or not.
Question from Dr. Ravi Pawar. Can be done whole exome sequencing?
Yeah, we can do a whole exome sequencing, but as of now, we are tied up with a company for the whole exome sequencing, but the counseling support and also the pedigree analysis and the other support is being given by us. But for the testing, I mean, we are just, outsourcing as of now.
Question from Rohini once again. If there is family history of male breast cancer,
breast cancer. Okay.
Yeah, should the near relatives, probably she wants to say that should the near relatives can also have that issue? I think that is what, because
yes, that totally depends on the kind of a mutation what he's having, and based on the mutation, the extended family can go a screen test. And those people can, if any pathogenic variant is present, which is similar to the patient, then that person can be kept under surveillance by doing a regular, X-ray or a, breast examination and all. That will be helpful for them.
Question from Dr. Rajesh. Are there specific indication for HER2 new mutation testing in breast cancer?
Any specific indications? Like basically, if you're finding a immunohistochemistry positive, that can be taken for the ERBB2, and also for the treatment, ERBB2 testing or HER2 new testing helps in giving a right chemotherapy.
Question from Dr. Meenal, saying that can genetic studies be done when baby in SITU in womb of mother? By saying so, she's trying to say that I'm pointing to role of abortions.
I'm pointing to role of the abortions. Yeah, any woman who is below the gestation age of 22 weeks can undergo a amniocentesis procedure, and we can do the testing. And then if it turned out to be a positive or a negative, then the counseling has been given, and based on like what are the outcomes of the testing, whatever we have done will be explained to the patient, and their questions has been taken up, and then the decision has been left to the partners or and also to the patient whether they have to continue or not to continue. It's up to their thing, but the counseling will be given for the positives and the negatives outcomes, whatever has been obtained from the testing.
Next question from Dr. Rohini. She has only written proband not available.
Sorry, proband not available.
Yeah, that is the only thing written. So requesting Dr. Rohini if she can okay. So the sequence is something like this, doctor, that proband not available. Okay. Is there any genetic testing in mother if first child has congenital deafness and dumb?
Yeah, we can do a general detailed pedigree analysis and can identify what kind of a testing to be done to the patient or to the proband or to the extended family.
Question from Dr.
That can be decided only based on the complete pedigree analysis.
Question from Dr. Sandeep.
Okay.
Can lifestyle changes reverse family diabetics?
Lifestyle changes, yes. Lifetime changes. Everybody has genes which are for some people the risk is been high. For some people the risk is low. The lifestyle changes. If you make some lifestyle changes and you have a risky gene, then it helps. If you don't have any risky gene, even if you make your lifestyle changes, it doesn't matter. It's just matter of being very cultured and I don't know. I mean, like I mean to say, if there is a risky gene, I mean to say, if you have a related genes where it is responsible for leading to diabetes or a familial history, then adding upon even the lifestyle changes which are worst will increase the chances of having a diabetes. But if you don't have any family history, and but the risk of getting the diabetes will come down. So it basically depends upon your genetic pattern. Like for what I suppose is, like your father is diabetic and you are not diabetic. So if you change your lifestyle, it will be very helpful, because already you are having a family history of diabetes. So if you change your lifestyle, it will help you in not expressing some of the genes which are responsible for the diabetes. Hope I've answered this question.
Yeah. Question from Dr. Rohini. Okay. Is there genetic basis for vitiligo?
Vitiligo, yeah, there are some genetic bases, but there are very few literature studies have been done on vitiligo. Yeah, because very less genetic syndromes or the data. It completely depends on the availability of the data. So the more you do the sequencing of the human, the more is the data. So in recent times, with the social media and all, now we started genetic testing very rigorously, and people are getting to know about the genetic testing and all. So the availability of the data helps a lot in diagnosing or in treating the genetic diseases.
Question from Dr. Muzammil: is Miller's mitochondrial abnormalities treatable?
Miller's mitochondrial disorders.
Yeah.
Okay. Mitochondrial disorders are not treatable. Any genetic disorders are not treatable, but manageable to a larger extent than to treatable. Yeah, here there are now coming up with the gene therapies like SMA. Now it is a treatable one. So slowly the gene therapy is been increasing worldwide, and we are able to treat many of the genetic disorders. And through management, it helps a lot.
Okay. Question from Dr. Rohini: please explain if it's possible to do prenatal diagnosis of autism.
Prenatal diagnosis of autism. Yeah, we can do the prenatal diagnosis of autism through a microarray or a genic testing.
The question she is asking is how?
Yeah, through microarray testing, through microarray on amniotic fluid if she is pregnant.
Okay. So
and genic testing would be the ideal one for the autistic panel.
So any more questions from the participants and the doctors, please feel free to come up. So doctor, I can't see any more questions coming up, in the chat box. So I think over to you now, because no more questions I can see from any participants.
Okay. Thank you for giving an opportunity to talk.
One more questions, Dr. Hang on. Dr. Rohini has sent one question that what are treatable genetic abnormalities?
What are treatable genetic abnormalities? Okay. Like in newborn screening, like inborn errors of metabolism, if it has been identified just after the birth of the baby, then you can manage a supplement food can be given, and you can manage, and you can make the life more better by giving this supplemental food if it is an inborn error of metabolism. And treatment like SMA can be treated, and Down's syndromes are these like Edwards or Patau's. These syndromes are related to the IQ levels. So these things can be manageable. You can manage them giving a speech therapy, or you can put them in a special schools, and Down syndrome children's make a very good lifestyle.
Question from Dr. Rohini: what is the cost of SMA treatment?
Yes, it is pretty costly, as we all know. Hopefully, in the past days also, when we were doing NGS testings and all, the cost was too high and it came down. So hoping for the cost to get reduced in future.
Is it available in India?
Yes.
And are there any genetic screening tests for GI malignancies we're doing, and where?
Yeah, we do, genetic testing for the GI. We do a GIST panel, like, or a oncogenes like KRAS, NRAS, BRAF, all these being checked for the GI.
Question from Dr. Tejasri. Ma'am, is important to do karyotyping in pregnancy?
Karyotyping in pregnancy? This is an
Yeah.
incomplete question, actually.
Yeah, that is what is written. So I request Dr. Tejasri if she can little elaborate the question.
Elaborate the question. I mean, like, what she meant was before pregnancy or after pregnancy. What is it? I mean, it's important to do karyotyping in pregnancy. See, if you have any history of abortions, or if you have a familial history of genetic disorders running in the family, yeah, then you have to do a karyotyping test, which is a gold standard technique and which is a basic technique in genetics. Okay, frequent abortion. Yeah, frequent abortions. That's what I'm telling. Yeah. So if he has any frequent abortions, then she has to abortions more than 3 is recommended to do a karyotyping test prior planning to the next pregnancy.
So I could not see any more questions, doctor. So one more questions from Muzammil.
Okay.
Any consultants are available at our Center for Genetic Medicine or treatment while we can refer patients?
I don't know what to answer for this question. Any consultants are available at our center?
So basically, we are basically into a diagnostic segment. So, and we are not directly dealing with any consultancy or prescribing any medicines. We only do the diagnosis part. I think that is what I can highlight towards this question. So karyotyping. So I don't know the name, but one question is
karyotyping and microarray in
patient
with repeat abortions. Okay, so karyotyping is a basic test and microarray is a high-end test of a karyotyping. So the cost wise, the microarray cost is too high when compared to the karyotyping. So just do a karyotyping, and if you cannot identify anything from karyotyping, then you can just do a microarray and then look for any chromosomal abnormality. And accompanied with the familial history would be helpful. Yeah, NIPT has to be done for every pregnant lady because it is recommended by ACOG, as it is as like that of a biochemical screening marker. NIPT need to be done for all the pregnant women, even if it is an advanced maternal age or high risk pregnancy. The NIPT must and should be done. Do you do immunocompatibility test for repeated abortions? Incompatibility test. I'm sorry, I don't do this testing, incompatibility test. Maybe this is something related to the pathology. How late we can do NIPT? How late? The early you do is the best. Any test at the time of pregnancy, as you can decide whether to continue or not to continue on it'll be based on the testing, right? So early is the best, and NIPT can be done only after completion of 10 weeks, gestational age of 10 weeks. And MTP can be done only till 22 weeks. So in between these weeks, you can do NIPT testing. Okay, hope I have answered all your questions. So if you have further questions, please do write a mail to me. I will be answering all your questions. Thank you for the sessions and attending my presentation.
Thank you, doctor, and thanks to all the doctor participants